So I think some more people are going to be coming in, but just so in the sake for that we stay on time and are fair to Dr. Samy's schedule here, I'll start with an introduction and then we can get going. So good afternoon, everyone. Thank you for being here today. We're really fortunate to be joined by Dr. Ravi Samy, who will be speaking to us about auditory brainstem implantation. Dr. Samy is a professor of otolaryngology, head and neck surgery at the University of Cincinnati College of Medicine. He completed his medical degree at Duke University and he did his residency at Stanford and a fellowship at Iowa. He is the director of the Otology and Neurotology Fellowship Program at Cincinnati, as well as the International Advanced Otology Fellowship. And he's a real expert in the field of auditory brainstem implantation and a pioneer. And today he'll be speaking to us about the technology and indications technique of ABI. We really appreciate you taking the time to be with us here today, Dr. Samy, and we really look forward to your lecture today. So with that, welcome, and please go ahead.
Thank you so much, Dr. Sturm. It's really a pleasure and honor. I apologize to everyone. I had to actually do this lecture earlier a few months ago, if I remember correctly, and I had to cancel on everyone. I had an add-on case, so I promised Dr. Sturm I wouldn't add any patients on, no add-on case or anything. So initially the title of this talk was going to be auditory brainstem implantation, and I am no pioneer. I appreciate Dr. Sturm's kind words. We're really the pioneers, are legends in our field, and I've got a lot of slides. One of the things I'd like to teach, and I think this is from my time at Duke, David Savison was the old chair at Duke, and he made sure that all of the med students actually spent the first 2 days of this core surgery clerkship reading about the history of medicine and surgery and an overview. And I think we stand on the shoulders of giants. And so there's so many things I've learned over the years. The ABI teaches you, it makes you think outside the box. And so that's why I changed the title, not just from auditory brainstem implantation to lessons learned. And my email's at the very bottom, so feel free to email me if you have any questions after this talk. So conflict of interest, research funding from these three companies, none of whose products are actually going to be discussed in terms of relationship, although Cochlear does make ABI, so do other companies as well. So when you look at your practice, so Dr. Sturm is starting his fellowship. I've now been roughly 2 decades into this. And one of my quotes that I'll use in a lot of my lectures is medical education begins with the patient, continues with the patient, and ends with the patient, by Sir William Osler, and legend in our in medicine, of course. One of the things to think about with our patients is that you're going to have complications. If you do neurotology skull-base surgery, you will absolutely have complications. And you can have that with any field, of course, right? You can do a stapedectomy and have a dead ear post-op. Let me tell you, the complications when you do neurotology skull-base surgery can be horrific. And it gives you a lot of gray hairs, and you learn from your patients, how do you prevent those complications? These are expensive complications, though, right? You have the ability to really alter a patient's life. And so here are a couple of pictures of patients of mine that went from becoming patients to actually friends. So I'm not breaking any HIPAA violations here because they're really involved with our ANA support group here in Cincinnati. And I'm going to put on this laser pointer here. So this is Emily Prater, who's the head of our local ANA support group. She's had acoustic neuroma resection, her husband Jason here, and then Jessica Taves. And Jessica does an amazing job at telling a story of her history, and she is one of the success stories for us for our ABI program. And Jessica initially had an acoustic taken out by Dr. Brackman on the left-hand side about 15 years ago, and she tells a story that the day she was supposed to have the ABI placed at the same time as her translab acoustic neuroma resection, the insurance company denied coverage of the ABI. And so she didn't get the ABI. And then her right side hearing started going away. She saw me for placement of a left ABI. Since that point in time, years had passed, and she heard about us and looked at clinical trials in Cincinnati. We work with Trent Hummel, who's at Cincinnati Children's, for different agents for NF2 treatment. So I said to her, hey, instead of doing a left ABI, what if we radiated the right tumor? So we did LINAC radiosurgery for the right tumor, and then ended up placing a right CI. and then ended up doing a left ABI. And so this is her activation day, September 2017, and she has just been a star performer. So with ABI, with NF2, think outside the box. This is a brutal disease, as I'll talk about as the slides continue. And my little baby girls, they're now 14, but once you're daddy's little girls, you're always daddy's little girls. So every patient that comes in, I teach my residents and fellows this. Emma is on the left, Gabrielle's on the right, is someone's mom, dad, brother, or sister. And so if you never forget that, and you treat every patient in your office with kindness, compassion, dignity, and respect, your waiting rooms will never be empty. It is amazing how over the years that relationship building, like my friendship with Emily and Jessica, is really been gratifying to me and hopefully for them as well. Now, these are legends in our field. So I talked about Dr. Sabiston, who was a mentor to me, was a legend in the area of cardiac surgery. On the left-hand side is Bill House. On the right side is Bill Hitzelberger. And both of these gentlemen truly were legends, the two Dr. Bills. So you have Dr. Bill House, who's considered the father of modern neurotology. So this is a person that was the first person in the world to use the microscope intracranially. And he taught neurosurgeons in a lot of ways: facial recess approach, cochlear implantation, auditory brainstem implantation, middle fossa approach, translabyrinthine approach. I mean, any one of those, if any of us had created or done, would built our career. And the fact that this one person did all these things, it's really amazing to me. But I would argue that Bill Hitzelberger, who worked closely with Bill House, is also very impactful for us neurologists. I think by the time Dr. House died in 2012, Dr. Hitzelberger in 2014, I had the pleasure of meeting Dr. House, talked to Dr. Hitzelberger actually on the phone. He was supposed to come out and do our first ABI with us, and then had some health issues, and things, of course, fell through, and we weren't able to get him to come out. He'd done, by about the time he retired, 6,000 tumors. No one will ever get that experience ever again. What makes Dr. Hitzelberger so impressive, though, is the fact that he was willing to work with, quote unquote, an ENT surgeon, because for a lot of neurosurgeons, that's not necessarily the case. The paradigm that these guys created, that teamwork and team mentorship, really should be what we all look at. And our careers as neurotologists, if you're going to be a busy skull-based surgeon, really means being close to your neurosurgical colleagues. And so for me, I've got a couple more slides on things I look at from a philosophical standpoint, and passing gratitude from Dr. Gans to my left at the day of graduation, Jay Rubenstein to my right, and both were amazing mentors. Dr. Gans is one of the best surgeons I've ever seen in my life. And then my growth continued after fellowship. Dr. Penzak, then Dr. Zuccarello, both former chairman of their respective departments, otolaryngology and neurosurgery. This is a program since the early 80s, was doing a lot of skull-based cases together on things such as petroclival meningiomas and basilar artery aneurysms. So, not a common thing. And then the torch is passed to my good friend and brother in arms, Norberto Andaluz, who's about my age, Jonathan Forbes. And then working with fellows, Dr. Doyle, Dr. Natura, our international fellow. And I think that our fellows over the years have been one of the most important parts of our program. You cannot have a busy and cutting-edge skull-based program without some amazing people. So from Sean Stevens, who is an MUSC grad, who's now at BNI, Gabi Kohlberg, University of Washington, Justin Golub, Columbia, all these different guys, Scott Shapiro now in Rutgers. It's you surround yourself with people smarter than you are, I think it makes you grow. So a lot of these guys have asked me questions that I was like, why aren't we doing it that way? Why don't we push the envelope and learn that old line of there is no such thing as a stupid question? I completely agree with that. So here we are talking about ABIs, but I will tell you, if the bulk of the patients that are ABI candidates are NF2 patients, reality is you work on this ladder approach, right? So whether it's lifestyle adjustment, lip reading, that's what I'll do for some of my patients just to start off with. Hearing aids absolutely works well, because some of the patients will have bad hearing in one ear, good hearing in the other. Do you do a bicross, amp cross hearing aid? Implantable devices, osseointegrated implants. And then the big question, especially for NF2 patients, what point do I think about CI versus ABI? And then in the future, NF2 is, of course, a different issue. Can we do hair cell and stem cell regeneration? What about injectables? So you really need to think about all these different options. And as I said earlier, with NF2, you have to think outside the box. It's not a cut and dry. Each patient is completely different. So as an example, let's pretend, I'm going to give you a case in point here, but let's pretend the right side is an old, if we had an acoustic on the right in addition to the left, how do you handle that in an NF2 patient? Well, this is a slightly different scenario. This is a 40-year-old Indian male who came to me with fluctuations on his left ear, his only hearing ear, right side congenital sensorineural hearing loss. And I did not want to take out the tumor, although I would argue on the left side with 3 episodes of sudden hearing loss that have improved with steroids, he is going to lose hearing at some point in time. So whether you look at the Denmark data per Kate Thomason and observed tumors, once you start losing hearing or having fluctuating loss, almost everyone loses hearing eventually. So I said to him, I wouldn't touch a left tumor at all. I said, let's leave that alone. I went ahead and did a right CI, had good intraoperative NRT. He only gets sound awareness on the right side. I said to him, let's think outside the box again. Let's think about left-sided radiosurgery. And then once you lose that hearing, let's do a CI on the left. He still wants to observe it right now, but these are the kinds of things you think about. My hope is as time goes on, his open set recognition improves significantly on the right side. Then he's going to feel much more comfortable, isn't he, than just having sound awareness. He's going to say, okay, I can hear well enough to talk on the phone on my right side. And then he's going to feel more comfortable. So he's got a little bit of touching of the brainstem by the tumor, but no significant compression, nothing of concerns yet, but it's a matter of time before this grows and creates problems. But I would say time is the issue with NF2 patients, getting them quality of life for as long as possible and keeping their senses for as long as possible. So ultimately, as much as I may like the idea of ABIs, just remember a cochlear implant will almost always work better. Now, there's some situations, of course, cochlear nerve aplasia, that's not going to be the case. But for a cochlear implant to work, you need the actual cochlea itself, of course. You need a cochlear nerve, but people forget about the labyrinthine artery. It typically comes off ICA, can come off the basilar artery, vertebral artery, or even superior cerebellar artery. And so I think what happens a lot of times is we do a good job, especially for the smaller tumors, of saving the cochlear nerve, but we disrupt the blood supply. And that's the big challenge. And that's where the ANT testing from MED-EL and all the different things, PROM-STIM, are trying to give us data on, is this a functional nerve or not? But we don't actually know about the actual blood supply. So you're talking about acoustics. The majority of patients that we see in our skull-based practices have unilateral acoustics, of course, and that's great because then you have another side that you can rely on for hearing and balance function. This is a brutal disease. I've had patients over the years. In terms of when I was thinking and preparing for this talk, and I really, it's been a pleasure to give this talk to all of you, but I learn a lot when I give these talks because it makes me look through the literature again, because it's been a few years since I've brushed up on all the ABI literature. But I can tell you in terms of mortality, yes, squamous cell carcinoma of the temporal bone, necrotizing otitis externa. I would tell you these are patients I've lost over the years, that I'll see them 6 months, maybe another 6 months later, and then they drop off the map. And then so there are patients I've had who I have no idea what's happened to them. Not only deal with tumors such as this, you deal with loss of vision, spinal tumors, and multiple ependymomas, meningiomas. It's a brutal disease. For all intents and purposes, it's a cancer, but it's a very slow-growing cancer, right? And patients have surgery after surgery after surgery after surgery. We just took care of a young lady recently who's Amish, who I would have loved to put an ABI in here, but we had no funding for that. They came in with zero funding. So we did a retrosig approach to her tumor. And she had a craniotomy for a supratentorial meningioma last year. And so this is tough. So keep that in mind for these patients. So while our options typically are surgery, radiation, observation for standard unilateral sporadic acoustics, I have much more thought about what am I going to do with our NF2 patients. Am I going to do fractionated radiation therapy? We have a proton beam center here. We use that more and more for some of these complex cases. When do we do a subtotal resection, but then there's a great chance of tumor regrowth. And then I remember Tom Rowland at one of our meetings a few years ago had a patient with pretty good sized tumors and was losing hearing both ears. And he asked what would people do in the audience in terms of management. And a lot of people talked about surgery for his tumors, very similar to the prior NF2 image that I showed. And his patient had very good response to Avastin, bevacizumab, right? And so, close that there. And so that worked for about 6 to 12 months. But those are all patients that do well for a while. Maybe you can get them in different clinical trials, but these are patients who continue to progress. So a lot of different options, but you have to make sure you continue to follow up these patients long term. For both acoustics as well as especially NF2 is making sure our patients who are very well educated. I've noticed, as many of you have that are fellows or faculty, that patients come in with so much data in their mind from different support groups. Facebook has been amazing, both good and bad, I think, with educating patients about acoustics. But you have to prioritize preservation of life, especially for NF2. Normal brainstem function. I've had, and many of you that are young in your career have not had this yet, I've had brainstem infarcts. I've had venous infarcts. It's horrible to see this on these patients. Maximizing facial function. And then you get down to hearing and vestibular function. Of course, these patients develop oscillopsia with that NF2. Hearing is important, but much less so. And so that's very much an issue I have. We had a teenager not too long ago, came in with mom and dad, very nice young man, unfortunately had congenital blindness. And the family wanted me to save hearing, but it was on a 14-year-old with a 2.5 centimeter plus tumor. I said, I can't save hearing with this. And he said, he's only 14. I presume he has NF2, doesn't have any stigmata of a tumor on the contralateral side or spinal disease. But I said to them, I had to redirect them multiple times to say, listen, we got to get this size tumor in a young man out completely. And so make sure you guide your patients properly. They can be educated off support groups and off the web, but they really need to be guided by you, who is the physician and surgeon for them. So let's talk now more about ABIs, and I'll go through some of the detailed history because it's fascinating what was done by the legends in our field. So first implanted by House and Hitzberger in 1979 in LA. I'm guesstimating about 1,400 worldwide, and some of the literature I've looked at showed back at House Ear Clinic, which historically had the largest volume in the world. Now, and that was primarily for NF2. If you look at the rest of the world, it's for non-tumor reasons. So compare that, which sounds like a decent number, to 300,000 plus who've had cochlear implants. So FDA approved in the year 2000, approved for use in patients greater than 12 years of age in the US. NF2 is the primary indication. I was at Iowa as a fellow from 2000 to 2002. In 99, Dr. Hitzberger came out and was put a device in a patient who did very well at Iowa, and that was part of the clinical trial. And then I had 3 or 4 when I was at Iowa that we did as well. And so that was my first interest and impact with the ABI and world. So these are the grow indications, which I think are fascinating, right? So we talk about NF2, and then I'll talk about Vittorio Coletti's work, which was just groundbreaking. I've had a patient who had labyrinthitis ossificans. This is a young lady who had CSF rhinorrhea, undiagnosed for about 8-9 years, believe it or not. And she was finally diagnosed listening to her mom, who said she'd go in multiple times to the primary care doc, and they just said she had a bad cold. But when you have a little kid who has rhinorrhea, people often don't think about CSF leak. She got diagnosed with the CSF leak when she developed meningitis, pneumococcal meningitis. So one of my buddies in anterior skull base surgery repaired the CSF leak. With insurance issues, by the time she saw me, we're hitting about day 75. with the labyrinthitis ossificans developing. So I was getting close to a point of no return. Finally got approval, did bilateral simultaneous CIs. Her left side actually did pretty well, but the right side was horrible with bad facial stem. And so she came back to me later, and we ended up doing a right ABI on her, and she's actually done well with that. So that's my one experience with that. And there's literature of temporal bone fractures, poor CI results, and you can argue my patient with the poor CI results is related to labyrinthitis ossificans. So this is all what you'll see in the literature now, a growth in options and expanded criteria for ABI placement. So this is from Kevin Wong and Dan Lee's paper. Dan Lee's done a lot of research at Mass Pioneer on ABIs as well. And so these are some great pictures for all of you to see. This is the very original design, 2.5 millimeter balls placed by House and Hitzelberger. One would be on the cochlear nucleus and the other in the remnant cochlear nerve. And then they moved from that to this paddle, and then this was the next iteration. First 25 patients all had single channel devices. Since 1992, initial studies in the US with cochlear were for 8 electrodes, and then they went to 21 electrodes, and that was part of the European trial as well. And this is the most recent paddle, and we also went from this body-worn sound processor, and many of you are too young to see how large these were back then, to smaller behind the ear sound processor. And this is the last generation of the cochlear nucleus 24 ABI. And then this is the most recent version, and the body looks very similar to 612 device. You can see the paddle there, the sound processor. MED-EL also makes one. It's not FDA approved. And there's another company that also sells in Europe and the rest of the world as well that has not been FDA approved. Now, this is a really neat view, by the way, of what the paddle is. It's 3 by 8 millimeters in size, and these are 21 platinum electrodes. I think they're 0.7 millimeters in size. What's hard for you to grasp from this picture is how stiff this electrode is. This is an incredibly stiff electrode, and that can make it a challenge when you're putting it in. And these are the Dacron mesh wings that are used. And so we typically trim the wings because they can be too large. They're meant to help kind of position, but I think they get in the way of visualization of the lateral recess of the fourth ventricle. So I typically trim those before we place the paddle in. Now, these are some great pictures. One of these is from Mark Schwartz's paper on neuroprosthetics from 2008. And then you can see the cochlear nucleus here. What I want you to understand is that we don't see the cochlear nucleus directly. It's primarily the dorsal cochlear nucleus that's stimulated, the ventral cochlear nucleus possibly as well to a certain extent. And so you're placing it with no surface anatomy that's helpful to say, yes, I'm in the right position. We all know when you put an electrode in the cochlea, for example, if you're doing a round window approach, you can actually see it make its turn at times in the basal turn. We don't have that luxury with ABIs. You're looking at the lateral recess, you're looking at the surrounding cranial nerves. The 8th cranial nerve can lead you to that, but if you're doing this for cochlear nerve aplasia, you have to rely on the 7th nerve, nervus intermedius, 9th nerve. And so you're putting it in, and then you're relying on your EABR to say, is it in good position or not? And that can be very frustrating. We'll talk about that more in a little bit here. So what's my experience? You know, I don't have a Hitzelberger or Mark Schwartz experience. This has been a humbling experience for me. My first 3 or 4 cases are Iowa, and then actually one of my patients came from Iowa, moved here, and became a non-user. And that's a problem with the ABIs, that you can actually have pretty good response with 8 to 10 electrodes. That's your goal, to get 8 to 10 out of those 21 to be active. And unfortunately, you have displacement post-op. That's one of the biggest problems of this. All were concurrent translab resection and concurrent ABI placement. And so we'll talk more about that's a challenge. Maybe if we're going to push our results further and further, you know, that's the history of medicine, right? We're getting close to 50 years with the ABI, and it's a stair-step approach. We're getting better. Some years we don't feel like we change at all, but over time we get better. Now, this is an MRI, my first ABI patient at UC. Dr. Penzak and Dr. Tu had done a right retrosigmoid approach. You can see the changes to cerebellum. And you can see just scar on the right side, and she was losing hearing on the left. So I said, all right, let's take you to the OR. Let's do a right CI. I had positive prom stim. I had no response post-op on the right side. In fact, in hindsight, I would have gotten a CT scan because she developed labyrinthitis ossificans, and we know that that can happen after loss of hearing after different skull-based surgical approaches. And so we decided, as we wanted to get the program started here, that this would be a good ABI candidate. And so this is a picture. Mark Schwartz came out. I'm very appreciative to Mark for helping us getting our ABI program going. And then my two colleagues and friends, Dr. Andalus and Dr. Zuccarello, we were all in the OR together. And you can see it's a very crowded OR. Everyone wanted to be there for the very first ABI. A lot of different inter-operative monitoring personnel. And that patient did pretty well initially. Challenges with these patients are oftentimes, not even related to the surgery itself. And I've got a photo of what happened post-op with her. This is a diagram, by the way. I love this diagram because it makes things very simple. If you think about the ABI being very similar to a cochlear implant, and then the branch off point is, do you put a cochlear implant in or an ABI? But of course, you need a functioning eighth nerve. And then this is a nice picture from Nicholas Deep and Tom Rowland, who's got a great ABI program at NYU. Tom shows the incision, placing the device in the well. Don't forget, though, you got to take the magnet out. It's important so you can do post-op imaging, because a lot of these NF2 patients, of course, need lifelong imaging. And so we want to have the ability to look at other intracranial tumors or lesions. Now, the other thing I'd say to you is, because some of the tumors are so large, our craniotomy may be larger than normal. Maybe you're doing an expanded translabyrinthine approach. Maybe it's a retrosigmoid approach that the craniotomy affects your ABI placement. So what I typically do is I will measure out, I'll take a silk stitch or suture, and I'll measure out the ABI, because I actually put the ABI in first before putting the electrode, because you want a fixed point here. You want to make sure you have a lazy S with the ABI active electrode. You don't want anything taut, because if it's taut, what you worry about it with patient head movement, you're going to now automatically displace the ABI. And so that's a nice little thing I've done. And then when the magnet's taken out, I'll put a titanium plug in there. And then patients just wear a little skin adhesive disc where they have to shave their hair a little bit. So this is our first ABI that we placed. You can see the massive segment facial nerve. And this picture doesn't do justice of how stiff it is, but man, you can see there's that little curve in it. And I had this sitting underneath the mastoid segment, the ground electrode there. And then post-op, oh, I'm sorry, let me show one more image. So this is the translab approach as it goes into lateral recess, packed with a lot of oxycell. And this is a picture that Ashley Wackham was kind enough to send me. So if you look at his literature, he actually had some cadaveric approaches to the lateral recess with an endoscopic view back in '99, way before endoscopic surgery really took off in the US. And so this is one of his patients he did with Dr. Hitzerberger in Wisconsin. And you can see the eighth cranial nerve. You can see the paddle. So this is what I was saying to you. I don't like these. I cut the wings off there because I think it can inhibit and affect the placement of the ABI if you need to get it even deeper in and adjust it. Intraoperatively, with the EABR, you're looking at 3 peaks. You wanted it, obviously, you're not going to have any of the eighth nerve left, cochlear nucleus, superior olivaric complex, and lateral lemniscus. So those are the 3 ideal peaks that you want to see intraoperatively. And you're monitoring the other cranial nerves. So don't forget these patients, you're often for the large tumor, you're seeing the 5th cranial nerve, you're taking care of the 7th nerve, lower cranial nerves. And with the ABI, you actually can cause dysphagia. We've had that with some of our patients, swallowing difficulties, aspiration risk, because you can be really tugging on the lower cranial nerves, not realizing that as you're putting the ABI in. We had a patient who we initially did a translab approach and initially had good stim in the operating room, and then post-op had movement of the paddle, had a lot of facial paresthesias and pain. And so we did a revision case with a suboccipital approach. And he's doing great now from the hearing standpoint, but he struggled for about 6 months. He's a 10 or 11-year-old, very nice young man, very mature beyond his years, and he struggled a lot with aspiration post-op. We had to get our otolaryngology colleagues to see him for swallowing disorder issues, and so he's in a much better place now 6 months later. These are the post-op scans. So this was the initial 612 device that I put in that had no benefit. You can see the ABI. This is the older cochlear 24 ABI. You can see the retrosigmoid craniotomy there, and the electrode on the right that was non-functional for the cochlear implant. On the left side, you see where the electrode fits into, and then the translabyrinthine approach with the abdominal fat graft here. Now, we activate these patients in the PACU about 6 weeks later, and we were looking for vital sign changes. And so I think if you have an incredibly busy program, maybe you don't necessarily need to do this, but if you're starting an ABI program early on, having anesthesia around, and we have an IV started, and making sure that we're not finding out there's any cardiovascular effect. And we'll look for the signs, as I said earlier, of facial paresthesias, tingling, pain, spinal thalamic tract activation. And the paddle, by the way, on the right side versus the left side, just mirror images. And it allows the audiologist to play around with the different electrodes and say, you know, mark an X by what works or doesn't work. And so they can start figuring out what their bipolar strategies are for these patients. So our patient, one of the things we struggled with earlier on is, and I think with my NF2 patients, I've noticed this, that these are patients who get tired of the healthcare system. It's surgery after surgery. She was a heavy smoker. Post-op, her wound broke down, and that's, of course, reported in literature. And so we have one of my colleagues in head neck oncology, Dr. Yash Patil, put a free flap in. And she used the device fairly well for about 12 months, but I've not seen her. And I don't know if she passed away from the disease or what's happened, but that's my guess, unfortunately. So this is a great read. If you're now talking about different ABI approaches, this is Bill Hitzelberger's read. The first paper was actually from the group House Ear Clinic in '82, and I was not able to get a hold of that paper, but this was a really good one. I've got some nice photos of this as well. So 51-year-old female with NF2 implanted in May of 1979. The ball electrodes, so they basically made these electrodes in their shop. I don't know if it's Jack Urban or who the person was that made it, and they pulled these electrodes out through the skin incision. And the lady actually did well for about 2 months. And then she came back later, and they offered to her later saying, hey, you know, and they do a good job in the paper talking about consent issues, saying, we have no idea what this is going to do to your brainstem, no idea if this is going to work or not. And the fact that she's heroic and willing to take on the risks, and they were as well, is really amazing. So they went back in 2 years later, and they used this different banded Dacron ABI. So different than the ball ones. And so they got good function with this. And then you can see here, they actually had the early unit was a percutaneous one, which to me seems like it's a very high risk for wound infection, of course. And now we have the transcutaneous one. And this is the initial body-worn sound processor. So she actually used her for, I think, almost 30 years, which is amazing that she lived that long and was able to use the device for that long. Now, the House group has also done a great job. Fred Lithicum, you know, who is a legend in our field as well, has done a lot of great histopathological studies. They did a study of one of their patients who was implanted at the age of 29. He succumbed 15 years later to pneumonia and NF2 disease consequences. And what's interesting is when you look at this, so the right side was implanted. This is where the electrode bed was. And these are the viable cochlear nucleus cells. And so you can look at this report as either a pro or a con. When they compare the right side to the left side, there's actually no difference in the viability of the cochlear nucleus complex. So on the one hand, they thought they'd see greater cochlear nuclei staining with the side that the implant. On the other hand, they said they're happy there weren't any long-term deleterious effects of 15 years, which is very important, because if we're starting to implant 2-year-olds for cochlear nerve aplasia, and that child's now alive for the next 80 years, what does that do to the brainstem? So at least this is good data at 15-year time point that it's not deleterious to the brainstem. So you go from the translabyrinthine approach to Vittorio Coletti, who's in Verona, who's now the chair of the department there. This is the first report of the retrosigmoid approach, and published in 2000. So 6 males, 1 female, and you have 2 different groups here. So all of these, the 22 to 37 year, were the NF2 patients. and he had one 4-year-old. So this is the first report in the world literature of someone having an ABI placed for anything other than NF2. So it's a really interesting paper and good read. Tumor size all the way up to 4 centimeters. And as we talk about the benefits and downsides of different approaches, one of the things I want you to think about is these tumor cases are going to be much longer. And I got to tell you, early in my career, when I was struggling trying to get my skill set, and you have a 4 or 5 centimeter tumor and you're doing a translabyrinthine approach and it's 8 or 10 hours and you're working hard to save facial nerve, and then now you're starting the ABI, it's not so much fun to start placing an ABI at 6, 7, 8, or 9 at night. And I've done that before. What's amazing is that he had 10 to 18 active electrodes. So one of the things I'm going to talk about in an upcoming slide is maybe the retrosig is actually the way to go, not only for this reason, but for other reasons that I'll show in a moment. So this is a great paper to look at for those of you interested in reading further. And this is, by the way, is a picture of the first common cavity cochlear nerve aplasia patient that he had, the CT scan on the left. So we did something very different, and I got to tell you, I'm very appreciative of Dr. Zuccarello. He has taught me a lot about the extended middle fossa approach. He and I have worked together over the years for petroclival meningiomas, basilar artery aneurysms, and he suggested, we did this on 2 patients, and our first in the literature, as far as I'm aware, of doing the extended middle fossa approach. And I'll show you why we did it on the first patient. So this is a lady who came in, both deaf and blind, came in with her aunt. She's about 30, late 30s, if I remember correctly. And she is a mom. She lives across the hallway from her aunt and her 2 sons, I think twin sons, if I remember correctly. She had a prior translab subtotal resection by an outside team, transferred to us. Left side's the right side's a dominant sigmoid sinus. And Mario, when he presented the case to me, he said, listen, we have a tumor here. Her facial nerve's already out. She's got these lower cranial nerves. How about we do it from an extended middle fossa approach? And I didn't think that would work, but kudos to him for pushing my envelope. You can see now we didn't touch any of the lower cranial nerves. We took out the superior tumor. You can see the shadow of the ABI without the magnet. And then this is a nice view on the CT scan of the amount of bone that was removed. But notice here, as opposed to a translab where we would have put the sigmoid sinus at risk in a dominant side, or even with a retrosigmoid, I left all that bone, but look how much bone we took away. And you see the big titanium plate, and then I packed it with fat. And then you can see her ABI there. There's a ground electrode. There's the active electrode there. And you can see the CT where the paddle sits in the fourth ventricle, lateral recess of the fourth ventricle. And I would tell you, is she a star performer? No. She can't use the device for lip reading. But I got to tell you, she hears environmental sounds for the first time. Excuse me. And she is able to have some sense of awareness with her kids, because before that, she's deaf and blind and can't communicate with the little kids. And so I love this quote from Thomas Mann: speech is civilization itself. The word, even the most contradictory word, preserves contact. It is silence, which isolates. So, that's another patient who we helped for a while, but she's been lost to follow-up. So my concern is she's probably succumbed to NF2 as well. And so that's the challenge with these diseases. Now, expectations. Think about these patients getting good sound awareness. We can deactivate electrodes if there's non-auditory side effects. Telling patients we're going to help you with lip reading, those are all important things. But if you have vision loss because of the cataract formation with NF2, and then the masks have been such a challenge for a lot of our patients, right? This really can make it harder. It takes a lot longer to perform in terms of programming than the CI. You can have displacement, may need revision surgery. And I like the idea more and more bilateral placement. And these patients need proper motivation and follow-up as well. This is a long road for the patients from a standpoint of putting up with all the different appointments they have. Now, from Mark's paper, a couple of things I want you to think about is now we have anywhere from 10 to 30% of patients having open set word recognition, and that's in the non-NF2 patients in particular, but some of the NF2 patients have shown open set word recognition. 8% have failed to respond to stimulation. And what Mark showed in his graph from his paper is that if you add on vision, and these are individual patients, if you have vision at the bottom on the Cooney sentence tests, that you add sound plus vision, they tend to perform much better. Almost every single one of them will do better when they have both put together. So this is a different subset of patients than cochlear implantation patients. So I think you can't compare the two groups. It's not fair to ABI patients or to us who are, as we're trying to push the envelope with this. The other thing that Mark showed in his paper that I thought was very nice is that the longer you use the ABI, that performance typically increases. But then he also said by the time they got out to 8 years, they only had one patient follow up at 8 years. So these patients do pass away from this disease and again get lost to follow up. The ABI clinical trial, this is actually, you can pull this from the Cochlear Corporation patient information packet for ABIs. This is with 60 patients with the older 22 Nucleus 22 ABI. These are some good numbers to remember. So 82% perceived sound and use the device. 85% showed improvement in open set sentences with lip reading. This is some good numbers. I thought 73% of patients would recommend an ABI to others. So these are patient questionnaires that were sent out. 61% of them use the device on a daily basis for about 10 or more hours. So I think these are some positive numbers. Doesn't mean the devices are amazing, but that overall patients are willing to typically undergo this type of procedure. But as with any skull-based approach, you deal with potentially life-threatening issues, whether it's stroke, seizure, meningitis, wound infection, abscess, damage to lower cranial nerves, damage to facial nerve. So, none of this should be minimized. And I think all of you that are on this today know that. So what patients do best with the ABI and how can we improve outcomes? So Josh, we have about 10 minutes. Does that sound about right?
Yep, that sounds about right.
All right, so I'll make sure I finish up on time and leave it open for questions for you guys. So, and how can we improve the outcomes? We don't want to see 5 years from now the same outcomes that we had 5 years ago. So Eric Wilkinson, who's a good friend of mine, I've known Eric since he was a med student at Stanford. When he was at House, worked with the group with Hitzberger, Brackman, Robert Shannon, Bob Shannon's amazing PhD researcher in this area, and then Doug McCreary, who is, I think, an engineer at Huntington Medical Research Institute. And they had 10 patients where they developed the PABI, the penetrating auditory brainstem implant. And I remember Eric giving talks on this, and these electrodes would be placed in because the tonotopic organization that we're all aware of with the cochlea is not the same when you're using just a flat electrode on the ventral and dorsal cochlear nuclei. And so the thought is by putting these electrodes, which are 1 to 2 millimeters in length and length here, and you can see them different from the surface electrodes. They did have some surface electrodes as well. Overall, it showed in some areas better performance, but not overall when you looked at speech. These electrodes were also much harder to manufacture. And so after the 10, they abandoned it. But I often wonder if you followed up these patients, do they have less chance of movement of the PABI? Are there other benefits? But that was a study that stopped at 10 patients. So, but the research continues. Now, this is one of my favorite papers. If you want to learn more about Vittorio Coletti, who really pushed the envelope, he was the first guy in the world, as I said earlier, to look at cochlear nerve aplasia. And this is a series of patients in audiology and neurology in 2014, 64 children, 60 children prelingually deaf. Age of implantation all was less than 10 years. He followed them up to 12 years after ABI, a variety of indications from aplasia to auditory neuropathy, temporal bone fractures. He did both cochlear and Med-El devices, and he used a category of auditory performance scale to look at the outcomes. It's an 8-point scale from 0 to 7. What's interesting in his group is 87.5% had awareness of environmental sounds within 1 year. 11% were able to speak on the phone, which is almost unheard of typically with NF2 patients. 31% achieved open set speech recognition. Now, the best results are in patients who had previous hearing. So if they already had the auditory pathways developed, so temporal bone fractures, post-meningitis patients. And then what's interesting is you push the envelope, 35 children had additional non-auditory disabilities. So when you look at that in several different ways, what you find out is that there's probably a ceiling effect for 7 on the CAP score, which is the highest score. You'll see improvement over time, but then they kind of plateau. And these are some of the lower scores. So I'm wondering if there's a ceiling effect with the CAP score system. I think the younger the patient, as you can see here, age is at the bottom here, better the CAP scores. Also, if they didn't have other disorders, right? So if you start having cognitive disorders, developmental disorders, developmental delay, that tells you those patients are probably not going to do as well. But maybe we look at those patients in a different fashion, that it's not good to just look at hearing alone. And then other things he looked at, that the patients who had other disorders probably stopped improving from a hearing standpoint, but on the CAP scores over time, the kids without additional disorders continue to get better performance. And then finally, patients here on this graph did best if they had just cochlear ossification, trauma, labyrinthitis ossificans. Interestingly enough, I think there is something going on differently with NF2. They did the worst. Now, you could argue they're typically older patients, but I think there may be something going on with the acoustics where it's causing retrograde degeneration of the cochlear nucleus, and that's probably part of the reasons why the outcomes aren't as good. One of the thoughts I wanted to bring up, though, is some of the push of why I may think the retrosig approach may be better. So this is Marcos Tadajiba, a brilliant surgeon, originally from Brazil. He's in Tübingen, Germany. And Marcus does his cases. He came and gave grand rounds here in Cincinnati about 7, 8 years ago. He does all his acoustics in a semi-sitting position. And when you watch him, he's a masterful surgeon. For those of you that are interested, he's got YouTube videos. He doesn't cauterize when he takes out his acoustics. He'll do 2 retrosig acoustics in a day, and almost any size. He is so facile and fast with this approach. Now, there's a risk of air embolus with the semi-sitting approach, but he uses irrigation only. And one of the thoughts is maybe with this type of approach, you use less cautery. Are we causing more damage by using cautery? Also, the angle to the lateral recess, I think, may be better with the retrosigmoid approach. And then it's a shorter surgery typically than it is after you do the initial 2, 3, 4 hours of drilling with a translabyrinthine approach. And then you're doing tumor work and ABI placement. And so now one of the things I've wanted to do more is delaying the ABI. So this is not an NF2 patient, but this is a tumor for our team where we're doing it in 2 stages. Dr. Zuccarello's debulking and taking care of the brainstem compression first, and a young patient, early 30s. So instead of doing everything all at once, let's pretend this patient is bilateral, and it's not, it's unilateral sporadic acoustic, but let's pretend the patient's bilateral. Why not take out everything at one stage, maybe do translab initially on this, and we've done this now in a couple patients, and then we place a piece of silastic, and I'll put a little non-absorbable stitch on it. We'll put it into the lateral recess. But finding where that lateral recess is with significant brainstem compression is not as simple as you would think, right? And yeah, if it's an experienced surgeon that's done a lot of these, I think that person could do better, but maybe we're going to get better outcomes. And that's one of the things I've thought about as we try to push this envelope further. Let's stage these. Let's do these translap first, come back later, 3, 4 months, let the brainstem heal and expand, and put the ABI in a second stage. It also keeps you from, as I said, getting fatigued 6, 7, 8 o'clock at night. Your whole team's fatigued trying to get good outcomes with the ABI. And then final few images I want to show you. Dan Lee's done a lot of work. He's looking at in mouse models, optogenetics, and using light to stimulate the cochlear nucleus. He's working with a group out of Lausanne, Switzerland, to create a very flexible array of the ABI, because the paddle is really stiff on the current models. So maybe something like this will allow us to contour things better. Final thoughts, there's a group out of Netherlands that is using ABI for unilateral tinnitus. And their initial studies in 10 patients, they started this back in 2017. And while I didn't like the idea of treating tinnitus with this, you got to remember, people are using deep brain stimulators and different electrodes for treating Parkinson's and seizures. Well, at our institution, in the last 30 years, we've had 3 suicides due to tinnitus. And so on the one hand, I don't like the idea of doing something like this. I think this is how you push the envelope, and they've got a lot of different inclusion criteria and exclusion criteria. So I think look at things much more closely. So future is bright. We're looking at everything from totally implantable cochlear implants to Thomas Lenart's doing the auditory midbrain implant. I think he's done 3 in a series now. And I think that we'll continue to figure out how do we help our patients who are really struggling with this. Final thought I want to give to all of you is a quote that I've used in a lot of my lectures, that we're in an era of corporatized medicine. We try never to forget that medicine is for the people. It is not for the profits. The profits follow. If you remember that, they've never failed to appear. So I'd like to thank you guys all for your time. I really appreciate it. And it's kind of sad. I've been here in Cincinnati for 17 years. It's been an amazing place, worked with a lot of amazing people, but I'm moving on and starting in spring of next year, thanks to Walter Jean, my neurosurgery colleague at the Lehigh Valley Health Network. I'm taking a chairman position out there, and I'll start in spring of next year. So I'll miss all my colleagues and friends here, but I hope that what I've learned with the ABI program in Cincinnati, that I'll work with Walter to continue to grow and develop my future location. So thank you, everyone, for your time and attention, and please feel free to ask any questions you may have. I hope I didn't go over things too quickly for you.
Thank you so much, Dr. Samy, for that really wonderful talk. And I have a couple of questions to ask, and then also we'll open it up to others. But thanks very much for spending the time with us today. I'm sure we all really learned a lot from that talk. I was curious to hear a little bit more about your experience with the non-auditory side effects, and whether when you encounter them, whether it's predominantly facial, autonomic, or whether you're encountering somatosensory effects too, given the kind of cross-modal innervation of some of the auditory brainstem structures, and how you kind of deal with those when you do encounter them.
So the hope is interoperatively, Josh, that we don't see those kinds of things. That's my goal, first of all. But what's frustrating is, because of movement of the paddle, we've had patients that did great intraoperatively and then had that post-op. My worry is early on, facial stem is very common. We can usually deactivate those electrodes. My concern is when I start having people talk about lower leg issues, we've not had any vital sign changes, but if they start having pain elsewhere, my concern is, can we take those electrodes out? But out of those 21 electrodes, if I only have 8 or 10 to begin with, and now I'm taking out other electrodes, my concern is patients are not going to do as well, right? Like, that's my worry about that. If you look at some of the data out there, you can have 3 electrodes is all you really need. But now you're starting to really worry. It's no different, Josh, and if you don't have a complete insertion of your cochlear implant electrode, right? The more electrodes you have sitting out, the more you worry about outcomes and performance. So yes, you can reprogram, but then at some point in time, you're reprogramming so many that now your outcome is going to be bad. That's a concern.
Thanks so much. There's a question from Meredith Holcomb from University of Miami. Her microphone isn't working, but I'll ask it on her behalf. She says that in Miami, they've been having a lot of trouble getting insurance approval for ABI and initial stim. It often takes the coordinators there weeks and weeks to work on just one case. Any advice on how to make that process go smoother, or what has your experience been with that?
Dr. Holcomb, you're absolutely spot on. I mean, it is a challenge. It is a fight. It is a problem for us all. I know there are some places that will just bill for the acoustic surgery alone. And so, yes, we've struggled with that as well. That patient that I just operated, a pediatric patient recently, I would have loved to put an ABI in here. I had no insurance coverage. And so, yeah, this is a challenge. I think persistence is the key. We've all faced this, whether it's single-sided deafness, cochlear implantation, whether it's hybrid implants. And I think I'll have at time patients work with their HR for their companies, because these are patients who don't have any other options. But yeah, there are times when we've just had to bill for the acoustic neuroma surgery. But I would say use that on a case-by-case basis, Meredith, to figure out, how that works for you. That's a good question, though.
One of the other things that I was wondering is if you have a sense from your experience with your patients and maybe other patients, that the impact of this on their quality of life has been, and obviously it's somewhat going to be variable from patient to patient, but for the patients who are achieving better performance with the ABIs, do you have kind of a sense of how it's impacting the quality of their life, given that their life, especially with the NF2 patients, is going to be quite impacted and shortened maybe by their disease? Is there any work that you've seen or?
Yeah. It's interesting, Josh, as I was trying to think, a lot of this is anecdotal, right? Like, I don't have 5-10 years of follow-up, as I showed you that slide from Mark Schwartz, we lose these patients after a few years to their disease. I think some of my happiest and best patients have been ABI with this on one side and CI on the other. And I feel like when I asked Jessica Taves about her device, I asked her, so you have a CI on one side, ABI on the other. What do you think about the two? She said, it's interesting. She said that ABI now gives her the sense of this three-dimensionality of sound that she didn't have before. But she wouldn't necessarily say that, yeah, the CI worked a lot better, which I thought she would. But it's a sense of a completeness of sound and being more aware of your surroundings. The patients are in for a long road and process, and they have to have good family support. I have had patients who stopped wearing the ABI, and you've got to ask them why. And so it's dependent on your audiologist, like Dr. Holcomb, right? In Miami, they've got a phenomenal program there. And Lisa Wenstrup and Teresa Hammer and Mike Scott, all the audiologists I work with here at UC and Cincinnati Children's have been amazing. So I would say overall, yes, they're happy. And some of them now, the fact that they're able to function well or function in an environment they couldn't before, I think is probably the best way to answer it, Josh. It's a hard number, though, for me to put on. If I said to you, hey, give me the data on this, right? I don't have the ability to do that per se. It's sometimes I feel like we talked about this earlier today. In fact, we discussed about Teddy McCracken's paper for our noon journal club on his quality of life outcome paper, and how sometimes I feel like my ABI patients are just happier than some of my cochlear implant patients who almost have such high expectations it's almost too great. And I think that my bar is set lower for the ABI patients. Say, hey, I'm going to help you with lip reading and sound awareness, but I don't want you to think you're going to get to be able to talk on the phone again. So I think when I reach that, they're happy, whereas my CI patients are thinking on day one of activation, they're going to talk on the phone again, even though we've told them a million times it's not going to happen. And I think some of it's that motivation and expectations that we as physicians and surgeons, audiologists, all of us have to provide for our patients.
I have another question from Dr. Holcomb. She wonders if you have psych and SOP kind of as part of your ABI team, and if so, do they do pre-op and post-op therapy and evaluations routinely?
So I have a psychologist, Meredith, who works with us, and Barbara Walker is her name. She's been phenomenal because not only has she been utilized for patients who have NF2, sporadic acoustics, mental health has been on the decline. I think pre-pandemic, 20% of Americans had a mental health issue. Now it's been staggering with everything from alcohol issues, drug issues. The last 2 to 3 years, we all know, have been atrocious. So she has been a godsend. And so the answer is yes on that. But you bring up a good point, Meredith. I have not had SLP involvement post-op with my ABIs. Can you, I don't know if you're able to get on as well. Is she able to get on, Josh? Can you have her talk? Because I'd love to hear from her if she's using SLPs. But that's a brilliant idea. I've not used that in the past, but maybe that's something that we need to look at for our ABI program.
So I am the speech language pathologist on the team at the University of Miami. But I have not yet, I have had one patient, a teenager with an ABI with single-sided deafness and an NF2. And it was what you were just describing, that it was really hard to get him motivated to wear the device. Yeah. And then so now we're actually having this discussion to know, like, should we evaluate them before the ABI process? And also, like, my feeling is that the psychology department needs to be involved because there's a lot of underlying issues and a lot of
I agree with you.
Things that need to be followed.
Yeah, I think that's very, I appreciate that input because it's interesting. When I got this talk together, I will tell you my NF2 population is some of the highest in terms of opioid use, pain issues, multiple surgeries, at times, depending. I've had teenagers, because that's also a tough population, as you know. The teenagers don't have the resilience and understanding that adults often do, right? And that they're in their point in their life when they're in high school and they're so different from every other child. They're always in the hospital. And I can remember one of my patients who I have not seen in years. Just every time I saw him, he had just attitude issues, was smoking a lot, was on pain relievers. And this is in the midst of the opioid crisis also, where the Midwest and Ohio included was being devastated. And I think those are some of the challenges. But if you're able to, I'd love to partner with you guys, figure out how we create a protocol. And I think I basically fell into the relationship with Barbara Walker. She introduced herself to me, didn't realize how good she was going to be for a variety of my patients, from Meniere's disease patients or acoustic neuroma. She's been wonderful. And maybe setting that kind of stuff up pre-op, and then expectations of with SLP. And for those of you that know, in the early days of cochlear implantation, everyone did have to go through a psychiatric evaluation, right? Because a lot of the ABI world, by the way, makes you also look at the CI world, which started in the 60s, 10, 15, 20 years before the ABI research began. And everyone had to have a psychiatric consultation because we had no idea back then if CIs would even work. Maybe that's a smart move with ABIs. Thanks for your input.
Hey, Ravi, Teddy here, McCracken. How are you doing? Thanks for doing this.
Teddy, did you hear that I did a shout out for you?
I appreciate it. I do appreciate it. But I think you bring up a really good point about expectations for these, because our field has been, our outcomes for cochlear implantations are typically quite good. And I think we all kind of have that mindset going in if that's what we want for our patients. And it's just not a reality for ABI,
No.
for that NF2 population. But I think it's really important to, for especially the trainees on here, to realize the importance of just environmental sound cues, right, in someone's life. I mean, when we kind of did our initial work, our initial focus groups, I mean, one of our patients who was the happiest of all of our cochlear implant patients was a woman who had history of bilateral meningitis, had just 0% word recognition, but had sound awareness. And that made her, move from someone who was kind of left in her apartment, would never leave her house, to someone who could go outside and felt comfortable then walking her dog, right?
Yeah.
And actually getting out in society. So that small incremental environmental sound awareness cue in the CI world, we think of that as, man, that's kind of the lowest level of improvement. But for these ABI people, I mean, it's a tremendous improvement from someone who lives basically in total, auditory darkness.
Yeah. So, question for you, since you were at House for your fellowship, tell me your experience when you're there. So, Dr. Hitzelberger had probably passed away by the time you were there. So, Mark Schwartz was probably there when you were there. Do you have a pretty good ABI experience there?
Yeah, we had a really, it was an interesting area because it was actually, Bill Hitzberger passed away when I was a fellow, and so Mark was doing them all there. But it was kind of an interesting period where kind of the Avastin, kind of the medical treatment for NF2 had kind of really taken over, and so there was a large period there where they were not doing that many ABIs, and then all those patients who were in the clinical trial started, the tumors all started growing, so we had kind of a gluttony of ABIs over kind of a 18-month period of those people whose tumor started growing after treatment. So, I had a it's a tricky problem, and it's almost like a microcosm of cochlear implant results, right? Where you have this huge range of outcomes of, people who are amazing, people who are bad, but it's like that's outcome is shifted kind of to a lower degree, but you still get such variability in people who are, I think when it's done in people's hands, it's safe to do. It makes a lot of sense to do it, to give people a chance.
Appreciate your input. Thank you.
So if anyone else has any questions, please speak up and interrupt me. But I want to just be respectful of Dr. Samy's time, and I really appreciate you coming and speaking to us today. It was a really informative and great lecture, and thank you for being here. And if anyone else has any other questions, please speak up. Otherwise, we'll wish everyone a great evening.
Thanks, everyone. Reach out to me. I had my email out at the beginning of the talk, so feel free to email if you have any questions. Appreciate your time.
Ravi, thanks.
Who is that? Is that Dr. Meyer? Oh, there he is. How are you, my friend?
Trying to avoid the bug.
I know you are. Hope you're well. Good seeing you, buddy.
Appreciate it.